Good.
Hello, this is Dr. Saud Anwar. We actually want to show you how you can actually use one ventilator to actually give breathing capacity and help to not one, not two, not three, not four, not five, but actually 7 people. And we can go up to 8 if we need to, but we wanted to show you at least with 7. And we've been working collaboratively together as a group of people who have from different backgrounds come together. I want to introduce you to Bob. Bob, tell me what you've been up to.
Hi, my name is Robert Connolly. I'm the owner of Interactive CAD Solutions. Less than 4 days ago, I got contacted by email if I could help out with coming up with a method of applying 4 hoses from one ventilator to 4 people. First thing I got was a hose from the anesthesiologist, and we did our first trials yesterday. Came out with mixed reviews. We had problems with the ventilators interfering. So I came back, I redesigned it yesterday morning. I sent the files to Kevin Dyer at Intercode Models. He 3D printed this CAD model overnight and supplied this morning. It's very simple. Has 4 filters with a coupling that goes directly to the ventilator. There's no issues with interference between the round filters or the square ones.
Good. So with this concept, what we've been able to do is this actually goes inside the inhalation as well as the exhalation part of the ventilator. And then these are the filters which can come together. This actually has 4 options. So the patient can we can have 4 connectors with one ventilator, and each connector can further be divided into 2 or more branches if we need to. Here we have Marvin. Marvin is a respiratory therapist, my star. You've seen him before do the good work. And what we have been able to do is a few things. I'll take this over here and I'll show you some of the things. So this is the inhalation part of the ventilator, and the ventilators we are using are the Puritan Bennett 840 ventilator system. And we actually have that same thing connected on the inhalation part. This is actually now, if you look, we have the 4 branches, and one of those we actually have put a T-piece and then divided it into 2 pieces. And then each 2 of them are divided into 2 more. So this one outlet is equal to 4, and then 5, 6, 7 patients are connected to this. And then on the exhalation part, again, the similar thing, we have a different color for this so that we can separate them out. This is again the filters that we have placed in. Again, you're seeing the T-pieces that we have connected with 2 extra ones and 2 on this side. And then we move forward and then see that there are 3 others that are connected to this. So when you step back, you see all of these different tubes, which are truly confusing, but actually there is a method to this madness. And that method is allowing for us to be able to currently ventilate 1, 2, 3, 4, 5, 6, and 7 patients. And we could potentially get another one and more so if we needed to. And here's the way to do this. What we have done is, and this is for the pressure control mode, and the inspiratory pressure we have kept at 25. With the inspiratory pressure of 25, we have actually getting a tidal volume of 3,241. Now that number scares you, but you have to divide that by 7, and it comes down to 470 or 450 something, which is exactly what you would want on these patients. So inspiratory pressure of 25 that you set up, and then we're obviously using 21% because we don't want to waste the oxygen in the hospital. And we put a PEEP of 10, and we can go up on the PEEP more so. But each one of these patients are getting a volume based on the exact settings that we have set up, and we are using the pressure control ventilator. And with this mindset, with this strategy, we can actually do ventilation for 7 at this time, but far more. You want to add more?
Nope, that is it. It's just a concept that works in a simulation, and if it comes down to mass casualties, this is a concept that I believe can be tried in the field if need be to have a clinical trial. Good. Concept works.
Now, one more thing I'll just add right now is that we actually did another thing where we were able to lengthen the tubes far more. And even when we lengthened the tubes, we actually did a pressure check on those, and with 20 feet of the tube, the pressure, the volumes were not impacted. So which is pretty fascinating that you can actually have a single ventilator which can go to different places, and we would be able to take care of the patient. So with this, I want to share with you later. If anybody has any questions, they can email us. Bob has been kind enough to be able to send us all the details of how to make these devices to make life simple for everyone. And please, if you have any questions, reach out to us, and we should be able to help you save more lives.
I have one thing to follow. The files to be 3D printed are open source, so anybody that emails me at bob@intcadsol.com can have a free model for 3D printing.
Perfect. Thank you.
Thank you.
All right. Thank you, everyone. Stay well. Hi, this is Saud Anwar, Dr. Saud Anwar. If you saw my previous video, we showed you about using one ventilator to ventilate 7 lungs. Now, there are some intricacies and important things to keep in mind. First of all, the reason we are having this conversation is because we're in the midst of a pandemic. Ideally, we know for a fact, and everybody knows this, is that one ventilator is meant for one person and one patient. So that's a pretty straightforward thing that everybody knows, and we work with that mindset. Having said that, the reality is changing a little bit, and for a clinician who is in the front line, my fear is, and that is the fear that everybody around us right now has, is that we do not have enough ventilators. And in the circumstances when we do not have enough ventilators, we have 2 options. Let people pass away without getting the support that they need, or try to fight the best that you can to be able to save as many people as you can. That is the principle that I work with, and that is the perspective of why I am trying to do what I'm trying to do at this time. So I think it's important to realize this. Now, anybody who's going to use this is going to be their own decision, whether they choose this or not. I feel it is important to have the tools and understanding how to use this. Now, today I'm going to show you some intricacies on the ventilator and how we actually have to work on this so we can be much more careful, and there are some interesting aspects that's going to help you be better prepared and also answer some of the questions and how to take care of challenges with the patients in this situation. With that, I'm going to take this video here and I'll take it up further. And this is the ventilator that we had seen before, again 840, and I'm going to turn this on. Now, when you turn this on, it's important to keep in mind that we will not have a patient attached to the situation. And if the patient is not attached, only then will the ventilator be able to be set. And if you remember, one of the things that we had set up, the multiple channels and contacts, keep this in mind. You can cap the ones that you're not using. So this is a smart way to do this, is to make sure the ones that are not being used are closed. So we are doing this, I didn't want to do the whole exercise all over again for the 7 ventilators, but I wanted to actually, 7 patients. I am doing this with 2 of those closed, and we are going to do 2 lungs to illustrate some important examples. The part on the inhalation side and the part on the exhalation side. Both of them are there. So now, with the ventilator setup, some concepts to be kept in mind. So I am actually going to set up an IMV mode, and I want you to understand this. There's a reason for it, and I'll explain that to you in a second. So when we do the IMV mode, just to illustrate, I'm putting a rate of 10, and I'm doing a pressure control mode. And the pressure control mode, I'll set that up. So first, we set up a weight for the patient, and the weight of the patient, in this case, I'm just going to go to a maximum for the time being. And we will, at this time, also go to IMV mode and pressure control. And I'm not going to give any pressure support, 0 pressure support. So there is a rate of 10. Tidal volume is not set as at this time because the pressure control mode, and 0 pressure support. And oxygen, again, we are not going to use any oxygen as we try to do this. And PEEP, now keep in mind, and I'll go over this as well, it's worthy to talk about. I'm just setting this up at PEEP of 10, and with that I'm going to accept this. And at this time, the machine is going to say that we are waiting for a patient to connect. Now, as we are setting up for the patient to connect, I will connect this patient over here. This is another patient, right? And I'll come over here and connect another patient. Now the machine should start to talk. You can come up here. Now here's the thing. The machine is right now a little confused because the tubes are so long and there are so many patients. So there's a way I can play with the mind of the machine. I will disconnect over here and put my thumb in here, and the machine feels that there's a cough, and right now immediately the machine starts to do its work. So we do turn the alarm off, and now you can see this lung is getting the ventilation, and so is the other lung getting the ventilation. Now the brilliance of the pressure control. First, let me just talk about the PEEP. The patients that we are going to deal with, for the most part, are going to be individuals who are going to have ARDS. This is the disease we're talking about, COVID-19. The patients, when they're in the intensive care unit and they're as critically ill, overwhelming majority of them will have ARDS. So we will need high PEEP. Some of the other critical ventilators or resuscitators do not have the capacity to give PEEP and do not have the capacity to give oxygen. This can give oxygen up to 100%, and we need that. And this can give a PEEP up to as much as you may want. It can give a PEEP up to a 30 if need be, or 23 in this, but we can bypass that as well. And that's why it's worthy to use a machine that can actually give a high PEEP, so improve the oxygenation opportunity that we have. Now, back to what we're talking about. The brilliance of the pressure control is that the pressure control will give the volume of air to the patient according to the compliance of their lung. And if it gives it along with the compliance of the patient's lung, we will actually have the opportunity to set up the pressure that we can set up, and that will be, if there are 5 patients or 7 patients or 2 patients, they will get the volume according to the compliance challenges. If the lung is very stiff, they will get less volume. So we know in advance if they're going to get less volume, their carbon dioxide levels will go up. So they need to be monitored, they need to be addressed, and there's a way to take care of it. And if we actually also have another situation, if we have a patient who is breathing above the set rate that I've kept at 10. So now if this is a patient, this patient is going to breathe at a rate of 10 right now with a machine. But if the patient starts to breathe faster, that is going to actually only impact this patient. And if you look at the other patient right now, this other patient is not being impacted. The other patient is breathing at the same rate as it is supposed to. But the first one that I'm breathing with is breathing at his own pace. That is the brilliance of the IMV mode. The IMV mode is going to work in a way that the patient who is trying to pull breath outside of the 10 breaths that we have set up, they will be on their own. So it would not impact all the other patients. So if we are going to use this mode, use a pressure control with IMV and play with the oxygen that you need for the patients and play with the oxygen that you need for the PEEP that you need for the patients. That is going to be a way to be able to reduce the impact of one patient having on the other. Now, one of the questions somebody said was that, okay, if a patient crashes or God forbid is had a cardiac arrest. Well, what you do is, like every other situation in the intensive care unit, when we do is, we actually have the patient be on a bag. We bag them, but as soon as you disconnect, everybody else is going to be impacted, so you have a stopper. You put the stop here so that none of the other patients, whether they are 7, 5, 8, or 12, or none, you actually have no impact on the rest of the patients by blocking this, and you do the bagging for the patient and take care of them. This is very simple, but you just have to be aware of this. The other issue that we talk about is that if the person is not getting the same amount of volumes, they're not able to blow off the carbon dioxide. If they're not able to blow off the carbon dioxide, their PCO2 goes up. Now, the patients in this particular disease are dying from low oxygen. They're not dying from high PCO2. But if you know that their PCO2 is going to be high, you can actually fix it by permissive hypercapnia that we do all the time with the bicarb drip and so on. But I think that's important. In principle, there is a way to do this. Let me turn the alarm off for a second. This is the low tidal volume because we have less of the other patient there. So with this in mind, I will actually share with you that first of all, you do this in the absence of ideal situation. if you don't have enough resources, if you don't have the capacity, and you want to fight the fight to save as many people as you can, you need to have experience and expertise and understand what it would entail, but also be able to save the patients who you can save and help them out, knowing that this is not a perfect situation, but in the imperfect world with the imperfect disease, you have to try to do the different things, and you have to have a mechanism to check it and protect the people that you can, and then take care of this. I hope this is going to help you understand some of the intricacies and the basics of why and how we can do this, and I'm sure there'll be more questions and I can address them as they come along, but hoping and praying that none of us will ever have to use this, but it's a good thing to have in our back pocket should we have to use this. Thank you again, and then please stay safe.